Good morning, Matt Riggins from Vidacare, giving a little Easy IO refresher here. I'm going to talk about a few of the updates, applications, landmarks, etc. Very few steps to make this a successful procedure. As I was mentioning, there's 3 needle sizes with the Easy IO system. We've got a 15 millimeter, 25 millimeter, and 45 millimeter. This is all based on patient tissue, not patient weight, so to speak. You will see patient weight recommendations on the back of these packages. As you see, 3 to 39 kilos here on the pink one. The blue will say 40 and above. However, those are just recommendations. They're not actual guidelines. This is all about patient tissue, which means if you were to feel over the insertion site like I'm doing here on my knuckle, okay, as you can see, this is very skin and bone, very little tissue. This could be your smart child, however, it could be also your frail, elderly, cachectic old lady, which would then qualify for the pink 15 millimeter needle.
Oh, okay.
So you can see that it's a lot about tissue, not so much about weight ranges.
So that's the first I've heard that.
Yeah, exactly.
Yeah, okay.
So that's one of the kind of changing points here. Selecting your needle is very important because you don't want to be too short, obviously. If I have a skin pad over the site here, which would be like generally the majority of adult tibias, you can feel a tissue patch, but you also palpate the bone behind it. Okay, that would be your standard blue 25 millimeter needle,
Okay.
and probably going to be used a good majority of the time for your adult patients. Okay. Yellow needle does serve 2 purposes. We were calling this the bariatric needle initially when it was launched. That is an indication for use if you have excessive tissue or you're really sinking your finger way into tissue, depressing into tissue, not really being able to palpate the bone behind it. That would be your needle choice. However, this is also the needle set we're going to use when we go into the proximal humerus, which I'll talk about for adults.
Oh, there's only one size for the humerus.
Exactly.
Okay.
We had some people that were rolling out the proximal humerus protocol, and they were using this blue needle,
Yeah, I saw
and they
that
were
one.
having dislodgement simply because the needle wasn't long enough to get through the musculature of the deltoid up here, plus get through tissue, plus sit itself in the middle of the medullary cavity. Okay?
Okay.
So you got to choose your needle set correctly. That's just a quick rundown. Test your tissue, figure out how much is there over the site, and then figure out your needle selection. Okay? Power driver, most people know about. This is our latest version. It's smaller. It's called the
That's teeny.
G3. Yep, it's got a battery light indicator on the back of it. Okay, so green obviously means go. When this hits about 10% of its shelf life left to it, it's going to turn red.
How long is that going
Okay.
to be, do you think, for most?
We're seeing roughly about 350 to 500 insertions. It's a kind of a various range. But these are lithium batteries. You don't have to charge it. This will be your indicator to tell you when you're going to be done. Okay.
Can you exchange those out if you have the older ones? How's that work? Or do you, if you're a hospital,
what we
how's
do
that work?
usually, like as we're doing right now for the rest of the year, we do a promotion where if you buy 10 needles, you get a free driver and a free case.
Okay.
So it's kind of a good way to switch out to get the newer model if you're
Okay.
interested. Yeah, a lot of people have that 90-50, which is perfectly fine. It works, and it's tough to tell when that one's going to die on you. This one at least has the light.
Okay.
Okay, so driver obviously has got a magnetic tip. Your packaging, these are the newest packages. Some people might have seen it. It used to come in a shuttle, but in this package you have a needle set, you have an Easy Connect, which I'll show you, you have an arm band, and we've also added this little red sharps block. Okay, so people didn't know what this was initially when it came out. You can, when you remove the stylet, stick the stylet right in the
Oh,
sharps
yeah.
block.
We never know
and
where
it
to
won't
put
go
those.
anywhere.
Yeah.
Yeah, it won't go
Yeah.
anywhere. Okay, so
That's
that's
a
what's
great
in the
idea.
package.
Yeah.
So you tear open your sterile kit, choose what needle you want to use. I carry around red needles just for training purposes. Red always
Red's
means training.
yeah.
Don't use these clinically in the field. You'll hear that little magnetic clip. There'll also be a little dust cap on here, and you're ready to go. We'll talk about quickly these black lines. A lot of people are familiar with what those mean, but these are also on the needle for a good reason. It's to tell you if you have enough needle to get in also. So when you do the insertion, as you should do properly, is always prick through the skin, okay, until you meet the bone. Okay, until you meet cortex, and you can't go any further. When you're at that point, if you want to bring it down, you can see multiple black lines on that needle.
Yeah.
As long as you can see at least one, it's telling you you have enough room to get in.
Oh, okay.
So if I chose the wrong needle, say I chose the blue needle and went in the adult proximal humerus, and I was at a point where I was pressing through the tissue and still going through tissue at this point,
Yeah, you're just,
and all those lines are covered up before I've hit the bone, this
Yeah.
needle would be too short.
Okay.
So always.
Well, I've never heard that either.
Yes.
That's the first time I've heard that too. Okay.
Standard, obviously IV prep, whatever your current protocol is, always prick the skin first until you meet the bone and check to see that you have one black line.
Okay. Awesome. Yeah.
At that point, what we do here, another thing we're really stressing is you don't need a lot of pressure on the driver. People will overpower this driver. You can actually kick it off. It'll heat up to a point if you're putting up too much pressure, and it'll stop the driver. So minimal pressure is key with doing an IO insertion with this device. All we do is once we can see the one black line, I know I'm good. I'm using minimal pressure, and you'll feel that little pop or loss of resistance. Okay, you can almost hear the driver kind of let go when it sinks in. We always want to secure that catheter hub. Don't just pull back the driver, because especially in non-weight bearing bones, you could pull that catheter right out. So secure the hub, pull back the driver like so, break that magnetic connection. Keep the hub secured while you spin out the stylet, like so. That would go in my Sharps block. Okay. And now I have my infusion port. In this area, people are kind of seeing these and now are ordering them, but these are called our easy stabilizers. Okay, it's a securing device. They're very good for pediatric use and also for the proximal humerus, because these are non-weight bearing bones. So they're softer. So it's good to set this before we do anything else. We can set the stabilizer piece right over the top.
Just fits right over the top.
Just like that. You'll see the tabs are labeled 1 and 2. Just pull those 2 tabs. It's a clear tegaderm, and it really will secure the site. You can see that even if there's some needle exposed there, the stabilizer will kind of telescope out so that it covers the whole catheter.
Usually I see the right to the hub. Is that right to the skin?
That's fine. All adult needles, whether it's proximal humerus or proximal tibia for adults, you can always put the needle hub right to the skin.
Right to the skin, okay.
You're never, as you can see here, this was a 45 millimeter, and I'm not even close to coming through the rear cortex. Okay. Once my stabilizer piece is on, I have 2 avenues to go here. Majority of these are still being done as a first line for cardiac arrest, so your patient's going to be unconscious. However, there may be applications for using this on somebody who is responsive. Sepsis protocol, you need massive volumes, whatever the case might be. If the patient is responsive, you've got to do one thing here, because if you remember the education we've taught, pain doesn't come from insertion, it comes from infusion. Okay, so if this person is awake or is somewhat oriented, what we do is we prep this line with 2% preservative-free lidocaine.
From the crash cart.
Exactly.
Crash cart lidocaine.
Yep, crash cart lidocaine. We'd have this Easy Connect primed with it, obviously.
With the right angle tip there, right?
Yep, we hook this up.
So how much lidocaine for an adult?
So what we've seen is we don't manufacture the lidocaine, obviously, so we can't give you dosaging, but what our literature shows is 20 to 40 milligrams is a good dosage.
It's only about 1 or 2 cc's, right?
Exactly, exactly. The key with giving the lidocaine is you got to think about how this system works. Okay, this is a pressure system. So if you looked at any of our fluoro videos, anything you put in here flows right out. Okay, so it would be the same with the lidocaine. So we don't want to flush the lidocaine in, because that defeats the purpose. We're trying to numb this area. So the way we give the lidocaine is in little half cc increments. Okay, so a little half a cc. We let it sit in that space.
If awake.
Yes, if awake. We let it sit in this space. 15, I'd say every 15 seconds, give another little half cc.
Can you dilute the lidocaine with some saline to make it like a 5 cc total or 10 cc? Like what you're doing there is a lot of volume there. It wouldn't be that much when you're doing the lidocaine. It's only like 1 or.
You're right. Yeah. So what we would basically do is just take your Bristojet and then just prime it down to the point where you've only got 1 to 2 cc's. Just waste it. So that way you know what dosage you're giving. And then just over those 15 seconds, give it in very small increments. Okay. What we see by a minute time frame, this is anesthetized enough where it's numbed, so that when you go to do that flush, the pain is less. So that's the thing with it.
Because the insertion is like almost like an 18 gauge needle. Is that correct?
Absolutely. I mean, you talk about anybody who's a tough stick. There's more pain associated with 3, 4, and 5 pricks with a peripheral needle than it is with one IO catheter. And it all comes down to the way the needle tip is designed. This is just the stylet, but you can see these are non-boring stylets, so they have a double bevel to them. So it's very, very sharp. So that's why pain of insertion is minimal. Okay. If our patient's unconscious, bypass that step of lidocaine. We move right to priming our line with saline. Okay, we'd have a pre-filled 10 cc syringe.
Ready to go.
Ready to go. This is most important with doing a successful easy.
Do you aspirate first at all from the hub site?
You can. That's a way to verify. However, depending on the patient's perfusion status, you never know if you're going to get something back. So if you don't get something back, don't say it didn't work. Okay. The way you figure out if it worked is by doing a vigorous 10 cc flush. Okay. The flush is going to meet resistance.
Should go in easy.
No, not really easy. Because you got to think about what's in here. In this medullary cavity is blood, there's marrow, there's fat. So when we are doing that flush, what we're creating, is if you looked at it like this, when we do the flush, we're actually popping open these pathways. Oops, sorry. So we're popping open these pathways, which lead to vessels, which then lead to
Yes.
central circulation. So if we do an easy flush, all we might do is open one pathway. Okay, so the pressure remains high, which is going to in turn not give you good flow. If you do the rapid flush, the 10 cc's, you might open 1, 2, 3, 4, which drops the pressure in the bone, which equals to a lot of flow.
Okay.
And that's what we're looking to do.
Right.
So your flush is going to look like this. Okay, you're going to have resistance, and then all of a sudden you'll feel a
Yes,
pop.
okay.
That's what you want to feel. So give that flush.
10 cc's.
I've seen some people even take 2 fingers on the syringe and give it like that.
Normal saline,
Yeah,
10
normal
cc's.
sa- Normal
Okay.
saline.
And if you see the skin swell up, you're in trouble.
Yeah, exactly. You're
Yeah,
monitoring for all your care here goes to same things with peripheral lines.
Yeah,
You're looking
okay.
for extravasation, you're looking
Right.
for infiltration, any swelling. But if you do that rapid flush and feel that release, you're going to be golden.
Now, there's always been a question of whether you can draw blood off the initial insertion, and
Right.
I understand you can. You got to discard about 2 cc's. Is that about
Exactly.
true?
Exactly. With doing any sort of lab draw off the IR route, you can hook the syringe right to it.
Before the
Okay?
flush?
Before the flush.
Okay.
Yep. You don't want to dilute it
Right,
with anything.
right.
So you're right. You can pull off your first 2 to 3 cc's. You can waste it or culture it only.
Oh, okay.
Okay.
I didn't hear
After
that first.
that,
Okay, so
You can pull your labs. I'll leave you a sheet on
'cause
blood
I've done a
work.
full set of labs on an
Yeah.
IO.
The only thing you're going to see things like whites and those elevated, but other than that, you can get a good list of
Glucose, potassium,
Yeah, oh, yeah.
sodium, the
Yeah.
main electrolytes. Okay,
Yeah,
great.
absolutely.
Good to know. Okay.
removal. This is the only time you ever hook a syringe directly to the hub. Okay, if you see anybody hooking a syringe directly to hub to do the flush, stop.
It's wrong,
okay?
right,
Because
exactly.
what that's doing
You're
is it's
widening out the
building up
hole,
a
right?
pressure, yeah, and you got a chance to actually crack.
So the only time a
catheter
syringe should be directed to the hub is when you pull back for
Pull labs.
for labs,
Yeah.
and when you're going to remove it.
Exactly.
Okay.
Exactly. So when we hook up the syringe, I like to have the actual plunger out a little bit. We turn it clockwise, which is kind of different than what people think. You usually think lefty-loosey. But turning it clockwise
Yep.
is what it's securing the
Yep.
seal between the syringe and the hub. And that'll break the seal, and then just continue to turn clockwise while pulling back towards you.
You guys
And you'll
stay in the
see.
hub or no? No.
Boom, right, just
Okay.
like that.
Oh, okay.
And it'll take some work to get it out of the adult tibia, I
Yeah,
can tell you
yeah,
that.
yeah, sure.
That's especially for somebody who is big, that's a dense bone, and it'll take some work to get out.
Now go over the
Okay.
insertion of the humeral site. And
Okay,
then
so
we'll
we'll
do
do all 3 landmarks quick.
Okay.
Obviously, proximal humerus is a newer site.
Yeah.
Proximal tibia is still pretty much most familiar with everybody. Proximal tibia is where we're going for pediatrics.
Right.
Okay, where we're finding landmark-wise is we always find the patella, okay, the kneecap. For peds, you want to miss the growth plate. Okay, so
Right.
what we do is we go 2 to 3 finger breaths below that patella, okay, and then 1 finger breath medial. Okay. For adults, what you'll be able to feel after the patella is this ridge, which is the tibia
The
tuberosity.
yeah.
Okay, so once we find the tibia tuberosity, keep 1 finger there and then go 1 finger medial.
Okay.
Okay, and it's a big flat spot. I mean, as I
Yeah.
can't even see it right here. Okay, it's very, very
Right,
big,
yeah,
healthy
yeah.
spot. Okay,
Okay.
the distal tibia, I have yet really in Remo to hear somebody use this site, but what we're looking for is the ankle bone, this medial malleolus.
Yeah.
Okay, we put our ring finger on that. We go 2 finger breaths above the distal tibia. This bone works anterior, so if you can pinch it off, we clean and go right there.
Anteriorly. Okay.
Yep, yep,
Okay.
it moves forward.
Yeah,
Exactly.
I've never used that site.
Yep.
Yeah.
Slower flow rates, obviously farther away.
Yeah.
You don't see a lot of people doing it, plus it's a very dense bone down
Yeah.
there. Okay. Proximal humerus, this is the newer site where we're doing a lot of
Yeah,
our
this is nice,
education.
yeah.
So why it's good, what you're going to read about is flow, okay? And you're also going to read about less pain, especially for somebody who's responsive. And you're also going to hear about the needle going in much easier because it's a softer bone.
Yes.
So 3 key things there. To identify the site, what it's key is always patient positioning. Okay, so we can see in the picture of our example here, you always have the arm as close to the abdomen as possible, and we need to wrap around. Okay, so if you want to get me here, arm on the abdomen, and you need to let this shoulder wrap around the midline, and obviously this patient's going to be on a stretcher.
Right, so
on
they're
a
laying
bed or something.
supine.
Yep, exactly. So when you wrap it around the midline, even if you can bump the shoulder up a little bit, all of a sudden you'll see this ball that'll just start to work its way out to
Proximal
you.
humeral head. Yeah.
Especially if you're on, obviously, a board or a stretcher or anything like that. The key here is if your arm is out like this, your bicep groove's exposed. So what we do by going like this is we turn the bicep groove in and we don't expose the bicep tendon. Okay, so that's the key of making this go like this. When we wrap around the shoulder, around the midline, and then let it bump up a little bit, all of a sudden this big ball starts to point right out.
So you could have, during cardiac arrest, you could have somebody hold up the elbow a little, raise the elbow up, which will raise the shoulder up? Okay.
Exactly. So as you look in the picture here, the anatomy is we obviously have the shaft of the humerus, and then it meets the actual humeral head, greater tubercle it's called, and that's the golf ball.
Yeah.
Okay? So if you can palpate this person's humerus, as I'm doing here, and you work your way up the humerus, all of a sudden you'll feel this notch of where the T meets the golf ball. Okay? That's kind of what you're looking for. And then if you were to go one finger breadth above that, is your actual humerus insertion site. Okay? Greater tubercle. You can't really miss this at all. It's all about patient positioning, but if you're able to palpate that humerus, come up to that notch, and everybody has it, you really feel where the shaft of the humerus meets the actual golf ball, that's where you're going right into.
Okay.
Okay? The angle of the needle, it's a little hard to see on me, but the angle of the needle is also key. When we go into this proximal humerus, we point it towards the same scapula, as you can see here,
yeah.
and we also coddle it down a little bit. Okay? And that goes directly right into the humeral head. So we're never going with the needle in this way. We're never coming in from the back. Once we find that ball, we're going on the ball towards the same scapula and just coddle it a little bit.
Okay.
Okay?
Yeah.
And you're right in. Again, we use the 45 millimeter needle for all humeral head insertions.
The yellow needle.
Okay. Yes.
Okay.
This isn't even
Over age limit is
40 kilos
40
basically.
kilos.
So
Okay.
about 18 or over generally.
Right. Okay.
You'll see they have full anatomy in the proximal humerus. But the reason we use the yellow needle here is if I was to use just my blue, and again these models I carry around are smaller than the actual anatomy of a adult, but you can see if I was to use the blue needle, okay, when I would flush the tissue, it's barely sitting in the actual middle of that medullary cavity. That's why we were getting dislodgements, because any movement there, it's a softer bone, it would want to dislodge. When I use the yellow or the 45 millimeter needle, you'll see that it sits itself pretty close to being dead center of the proximal humerus. Okay?
As far as it goes, the center? That's,
Yeah.
really, I'm thinking I'm going to go out posteriorly. And
We've used 68 millimeter needles and still couldn't penetrate the rear cortex.
Holy cow, okay.
So it's a very, very big site.
Yeah.
So with that said, being so big, that equals big flow, a
Yes.
lot of flow. Flow rates, what we've seen, especially if you're on some sort of pump or pressure, you can get 10 liters per hour out of the proximal humerus. That's a liter every 6
so you
minutes.
can actually induce hypothermia
Absolutely.
using a
Absolutely.
proximal
Absolutely.
IO. Okay.
Yeah. We're starting to see studies take place for using the proximal humerus for putting contrast dye through also. Okay, so things like that, because the flow is very, very fast. Anything you put right through here, obviously you can see from why you get such great flow is because immediately when you enter that space, you're entering subclavian, okay, and you're in the subclavian in
It's
about
almost
less
like
than a second.
central line?
Exactly.
Without all the risks, okay.
Exactly. So where we're seeing this a lot is being a bridge to a central line, get this immediate access, pump them up with whatever they need. If they need the long-term access, this can still only be stayed in for 24 hours.
Right. Okay.
So it's your initial line, bridge line, and then you could go do your full sterile barrier central line if the patient needs long-term access.
Now, what is the most common complication of the humeral IO insertion? Is it dislodgement? Is it?
It's dislodgement.
usually
It was dislodgement from using too short a needle.
That's right.
Other than that, as long as you position your patient correctly, okay, you can't miss this site.
Okay.
And you'll notice as you guys kind of, with whoever your medics, or you get them against a wall even, or on a stretcher, on a board, and you place that arm back and let it bump up, you're going to see that humeral head come right out at you.
Now, I also heard that you can actually take your two fingers along the shoulder, go like this, and then in the middle, then come over immediately. Is that
You
also
can.
a
You can.
technique
There's
to do?
several ways, and it's going to be, I'll leave you with a bunch of training CDs.
Okay.
Another good way for people to think about once your patient's in the correct position, a lot of people have given an IM. Okay, so they know where to give an IM. As I'm pressing
Sure.
my finger,
Yeah.
it's very spongy. It's a lot of tissue where you give the IM. As you move forward, you'll notice there's not much tissue there now because I've actually hit that humeral head. And that's the start of your
That's where we
landmark.
got it, yeah.
And you'll see it'll work quite a way over, almost about 3 centimeters. So when I pull my shirt back here, that's a big, big site that you can go after.
That's a whole area right
That's
there.
the whole
All
area,
this here,
exactly. That whole ball, whole entire ball.
Okay.
So I am spongy.
Yeah.
You work forward, all of a sudden you can see there's not much more tissue there because I'm now hitting the ball of the humeral head, and this would be in my insertion site, pointing it towards the same
Scapula
scapula.
and down.
Yeah, exactly.
Okay. Oh, wonderful.
Contraindications, this will
yes,
be the
okay.
last thing. Obviously, we can't use this on somebody who's got a fractured targeted long bone that we want to access. So stay away from fractures. Infection over the site, also
Okay.
stay away from that. And something we didn't think about initially, but we've seen a lot more knee and shoulder replacements. So if you see
Oh,
that
yes,
midline zipper
yeah.
scar,
Yeah, you don't want
think
that.
there might be titanium in there or something, stay away.
Right, okay. And for pediatrics, for lidocaine, if they're awake, is it?
Pediatrics, yep, you can still give a lidocaine dosage. That dosage is 0.5 mg per kg. Okay.
Again, the preservative-free lidocaine.
Yeah, exactly. Same
okay.
stuff.
Okay.
You probably won't actually see as much pain with a PD as you are going to be with an adult, simply because there's not as much fat and marrow and stuff in the medullary cavity. It's pretty much blood, so it's easier to move when you do the flush.
Okay.
So the pressure doesn't build up in pediatrics as much as it does in adults, which means less pain for peds than it is for adults.
Okay.
But you can see the last little thing I'll show you here is obviously when we teach pediatric insertions, we're talking about using very, very little force on the driver. Okay, so this would represent pretty much as low as I'm going to go. 3 kilos is what we're FDA approved for. This would be about
That's the minimum weight.
Yes.
So a newborn, full-term newborn, you can use
Yeah,
that.
absolutely.
Okay. But not a preemie.
No.
Okay.
I mean, 3 kilos, you're right, gets down
7,
to
8
pretty
pounds.
much. Yeah,
okay,
exactly.
Right. Okay.
So that's kind of what
The
they're.
preemies, you can use the umbilical if you need
Yeah.
access.
Yeah.
Yeah. Okay.
So you'll see small tib fib here, and the key is, even though I have a longer needle, this is my blue needle, so I wouldn't be using this on this patient. I'm going to just show you for demo purposes. You can see that would definitely go all the way through.
Yeah.
Okay. So what I do is, I always prick the skin just like I always do. I give it a little firm push here just to know that I'm on the bone, and then I'm just using the weight of the driver. So basically, you see my hand here. I'm just using one finger, and I'm just letting the weight of the driver do the insertion. And the minute you feel that pop, take your finger off the trigger. Okay. So you can do that over and over and over again. You do not want to apply a lot. You do not want to apply a lot of force to this. Just let the driver do the work. And every time you feel the pop, just take your finger off the trigger.
Then you're in as far as you should go in.
Exactly.
Even though you have exposed needle.
Even though you have an exposed needle, and I wouldn't be using this one on this patient, but even if I had an exposed needle, that's where you could use the stabilizer, which you could see with just telescope up.
Okay.
Okay.
Well, okay, Matt Riggins from Vidacare. Thank you very much for a very informative info session on
problem.
the
Thank
IO
you.
appropriate use. This is Dave Williams from Ellenville Regional Hospital, signing off. Thank you.